Welcome back, class. Today what we're going to cover are mainly breathing emergencies. And we're going to get into asthma, COPD, and a couple other things then too as well. But let's touch on a couple quick scenarios just to get an idea of what we can do with our current skills. The first graders are playing a game in the class, and when a 7-year-old child starts running and then suddenly collapses to the ground, the scene does appear safe. You check and find that the child is unconscious and does not appear to have any injuries. You tell an assistant teacher to call 911 and get the AED with pediatric pads as you continue to check the child. You are the only person certified and trained to perform child and infant CPR and AED. So, what do? Well, right, we see the child collapse. When we see a child collapse, we think first and foremost that this is more than likely going to be a cardiac emergency. But when we see a child when we do not see the child collapse, that's when we go first and foremost believe that it is a breathing emergency. So in this scenario, right, you see the child collapse. You want to go ahead and do your basic ABCs, right? After you tap the child, are you okay? No response. They're getting the call for 911, AED, so on and so forth. You do your head tilt chin lift technique for 10 seconds looking down the body, right? And then you give 2 breaths and then start with CPR, okay? So again, this is a cardiac emergency, but with every child and infant, we always begin with those first 2 rescue breaths before we start giving our 30-to-2 ratio of compressions to breaths, and then doing that 5 times in a row for that 2-minute bout, and then going again once we've checked for 10 more seconds, those ABCs again. Remember, as soon as an AED becomes available, we hook that up to the child and get that analyzed in the heart rhythm. Number 2, while at a family gathering, you are at a local amusement park, you and other adults are sitting around a picnic table talking about your sister's 8-month-old baby, who is nearby in the stroller. You discover that during the conversation, the infant is motionless. You're the only one trained in first aid and child CPR, so what do? Well, right, you're right there, so you say, hey, can I check your baby? Your baby's not breathing. I'm certified in this. So you do the basics, right? You pull the baby gently out of the stroller, lay the baby on a firm, flat surface, and do our ABCs check. We want to make sure we're giving rescue breaths first and foremost to this baby. So again, we know it's no breathing. We give 2 rescue breaths. Then we look down the body for 10 seconds in this scenario. All right? Remember, those breaths have to be around the nose and mouth at the same time, so if a breathing barrier available, very good. If not, right, mouth to contact, direct contact is going to be necessary. Okay, breathing emergencies, let's get into it real quick. So breathing emergencies are any respiratory problem that can be life-threatening to the person's life, and these could be respiratory distress or respiratory arrest. So just like cardiac arrest or distress. Distress means they're trying to breathe and it doesn't sound normal. Arrest, no breathing at all. And when we have no breathing at all, 9 times out of 10 it's going to lead to, right, no circulation then too. So it's pivotal that we have somebody breathing and circulating blood at the same time. Common causes of respiratory conditions would be asthma and other illnesses. We have airway obstructions, so that could be like an anatomical or mechanical blockage. There could be like a baby carrot, right? Somebody could be choking on a foreign object. Or there could be something anatomical, meaning that it could be like the epiglottis, the flap tissue that separates the trachea from the esophagus, or the tongue could be swollen, or even the tonsils. Now, the body does need oxygen to survive. So without oxygen, right, what's going to happen? The heart will stop beating. Then blood will no longer be moving throughout the body, and brain cells can start to die within minutes, like 4 to 6 minutes basically. And this can cause permanent brain damage. That's why it's pivotal for us to recognize these conditions and start giving the proper care. Let's define a couple of those ones more time. Just like as I did say, respiratory distress, right? Somebody is having difficulty breathing or requires extra effort versus respiratory arrest, stops breathing altogether. And again, normal breathing is going to be considered normal when it's regular, when it's quiet, and when it's effortless. The average person breathes about 12 to 15 times every minute. Other things then too, all right? These are some of the conditions that we could be dealing with. COPD is the first one. So this is right in your book. COPD is constructive, right? It is chronic obstructive pulmonary disorder, COPD for short. But it is a long-term lung disease that is when people are having trouble breathing due to the damage to the lungs. They could have partially blocked airways. Their air sacs deep within their lungs may not have the ability to fill with air properly, or they could just be a smoker, and that could be causing the COPD then as well. But our signals are going to be very similar for a lot of these lung conditions, right? They tire easily. They have loss of appetite. When somebody has COPD, you'll sometimes see them hunched over a little bit, trying to take in more breath because they got their pierced lips, shoulders raised to try to pull in more oxygen. They may seem confused because of the lack of oxygen, and they may have more of a round barrel-shaped chest because they're constantly trying to force more air into their body. They can also cough up a large amount of mucus. Emphysema is that main type of COPD, which comes a lot of times along with smoking. So they have a very extreme difficulty breathing. They have shortness of breath. They cannot exhale very well. And then more advanced cases definitely lead to that weakness, confusion aspects, and possible cardiac arrest. Bronchitis is another COPD. Bronchitis is inflammation of the main air passages to the lungs. When you have bronchitis, this can be considered acute or chronic, but the signals are going to be the same for both. It's chest discomfort, it's coughing that produces mucus, fatigue and fever, wheezing and possible shortness of breath. But some other additional signals that we might see with this bronchitis is that their ankle, feet, and legs could be swelling a little bit more than the average person. They could have frequent respiratory infections, and they could have even like blue lips. Hyperventilation is a more common situation that we could probably come upon. Hyperventilation is when somebody's breathing faster and deeper than normal, and the body does not take in enough of that oxygen then that's being respirated. And oftentimes it's from times of fear or anxiety, but other causes could be a head injury or severe bleeding. Any kind of traumatic injury could cause hyperventilation. Asthma definitely could cause hyperventilation, and of course exercise. That's something. So we have to be able to see and recognize what the problem is coming from. Signals, though, same as always, right? Dizzy, confused, perhaps, not getting enough air, feels anxious. Main thing is what we can do is have them slow their respiratory rate, get them to breathe in through their nose, out through their mouth, calm them down. That's why the paper bag is useful. It makes them focus on breathing all the air in so that when the bag closes, breathing all the air out so the bag opens, and slowly and consistently doing that. Allergic reactions are another type of respiratory condition that we could be dealing with. This is when their immune response doesn't necessarily attack the foreign substance effectively. And we can have something called anaphylaxis occur. Now, anaphylaxis occurs when there's a severe allergic reaction that's causing then a rash, the tongue and or throat region to start to swell up. The person can look very anxious, have a lot of anxiety, fearful, but you'll see the blotches of red spots of rashes accumulating on their neck, their throat, their face, even their arms. They're going to feel a tightness in their chest or throat, and then you can start to see that swelling arise. Anaphylaxis is very dangerous. Their tissue could swell up so much that they could block their trachea. Now, skipping ahead from anaphylaxis, again, that was that allergic reaction where the throat tissue swells up. We go into a condition called croup. And croup is harsh repetitive coughing. It's more likely with children under the age of 5, and it's just a very harshful, constricted airway sounding, high-pitched wheeze, I guess you could say, a barking cough, and it does not sound pleasant whatsoever. It usually occurs more oftentimes during bedtime or evening time than too with kids. Main thing is, take them to the doctor, get them checked out, or at least call your physician. Epiglottis. Just to talk about the epiglottis, there is a flap tissue, so every time we swallow, it diverts food down our esophagus instead of through our trachea. So great thing. Sometimes if we laugh or talk or while we're eating, sometimes we can suck a little bit of food and it'll get stuck in our windpipe down our larynx into our trachea. But if we cough, repetitive coughing usually pops that out. But if it gets pulled further, then we have choking going on with a foreign object. Well, in this case, we're just going to focus on the epiglottis. The epiglottis sometimes can get swollen, just like with that anaphylaxis aspect. So if that is swollen, that can sometimes stop breathing and it may cause severe breathing problems. But this is usually due to infection. So infections we usually see. Infections have fever along with them. So check the person for fever, and that can kind of tell you, call the doctor to get some more medical help. But other signs and signals are just the severe sore throat, trouble swallowing. It can be painful to swallow. Their voice could sound totally different. But the worst case, if there's infection, they could have shaking and chills going on, even drooling. A couple other signals of respiratory distress when we're looking at adults, in general, trouble breathing, right? Weird, abnormal breathing. Trouble speaking, right? People gasping for breath. If there is an unusual amount of moist or cool skin going on their body, they could look very flush or pale or even blue in appearance. Very dizzy or lightheaded. They could be very fearful of things. They could have severe pain or tingling in their chest, on their hands, and their lips. That's a sign that they're not getting enough oxygen. So just generalized respiratory distress. These are some of those signals. We need to be aware of those. A couple for children and infants that we need to focus more on is agitation, right? If a child, a baby, can't tell you what's going on necessarily, they can't formulate the words yet, but if they just seem very agitated or unusually fast or slow breathing, they seem extremely drowsy or their breathing's noisy. Sometimes you can see the nasal passages flaring. That's a sign that they're not getting enough oxygen or not breathing correctly. Sometimes other things then too, the chest appears to sink in with each breath, and those are the intercostal muscles retracting. Okay, if that's happening, very bad sign of troubled breathing. And the last thing but not least thing would be a very increased heart rate. Remember, heart rate is cardiac output is a combination of stroke volume and heart rate. So if the stroke volume is low, heart rate's got to go up to get more oxygen to get into the blood. And at some point, that heart rate's going to just keep going up higher, and that oxygen's depleted. Respiratory distress, if there's no oxygen in the blood, we're going to have a very bad scenario coming on. So contacting the proper medical professional, calling 911 if it's a life-threatening condition, we do so. Signals of respiratory arrest, I think we get this pretty well, right? There's no breathing at all. They're unresponsive. They look gray or bluish in color. We call 911 immediately for that situation. We check the scene for safety, obviously, because, right, maybe they were under respiratory arrest because they were breathing in some kind of fumes or something like that. Make sure you're safe first before you enter the scene. Tap the person, are you okay? No response. We call 911. If we need to move that person for safety, we do that. But then we do our ABCs, airway, breathing, circulation. Once we determine if there's breathing or no breathing, then we decide the next course of action. A couple more things then too, okay? For an adult, child, or infant having trouble breathing, help the person rest in a comfortable position, usually sitting up. Check for other conditions then, and if the person cannot talk, have the person nod or shake their head to answer you questions. Reassure the person that things are going to be okay and continue to monitor for other additional signs and signals of changes. Keep them from getting overheated or over-chilled, and assist them with any prescribed medications or even an EpiPen, or an epinephrine auto-injector is what it's called. And there will be a video later on showing you how to administer an EpiPen later on. Hyperventilation, try to get the person to relax or breathe slowly, right? And be alert that an airway could be partially or completely blocked. That way we may have to be performing abdominal thrusts and a combination of that with back blows. Okay, now this is the big part here. If an adult is unconscious and not breathing, right? If an adult is unconscious and not breathing, we're going to go ahead and begin CPR with compressions. We always do that with an adult. We start with our 30 compressions, followed by 2 rescue breaths, 5 times in a row of that, and then we rechecked for breathing and circulation for 10 seconds. If an adult is not breathing because of a known respiratory condition, though, or drowning, this is where we give those 2 emergency rescue breaths after checking for breathing and before scanning for bleeding, right? So we look down the body, we're looking for breath. Well, we've checked for breathing, we give those 2 breaths, and then we give a scan of the body to see if there's any other problems. Then we go with our compressions. So think of it this way: respiratory distress or known respiratory condition, known drowning, we give those 2 rescue breaths first before we start with our 30-to-2 ratio. Now for a child or infant, if they are unconscious and not breathing and you did not witness the collapse, we're going to give 2 rescue breaths to start with after checking for breathing. Okay? Then we go ahead and do our 30-to-2 ratio again. So again, you do not witness the collapse. That is when you give those first 2 breaths immediately. An asthma inhaler is something we might have to help somebody with. Sometimes it's a chamber-looking structure where they squeeze it, they breathe in the medication, and they hold it in for an extended period of time, like 5 to 10 seconds. Well, some of them are made with chambers attached to that where they do slower, steady breaths over time to disperse the medication slower. make sure you know what the inhaler looks like. So check it out in your book. There are great pictures to show you exactly what these inhalers are like. Asthma, to fix this problem, we use the inhaler, but sometimes if those aren't around, we're going to have to call 911 to get the proper emergency technicians on the way to help that person. The signs of asthma are often marked by hoarse, whistling sounds or wheezing after inhaling or exhaling. Okay? Sometimes coughing after exercise, crying or laughing could signal an asthma attack as well. So watch the movie Signs. That'll show you a great example of what an asthma attack might look like. But the additional signs that we see are just generalized trouble breathing and shortness of breath. There could be shallow or rapid breathing. There could be sweating, tightness in their chest. They can't talk, and they look very fearful. The main thing is that if they don't have their asthma inhaler with them to administer that medication, we call 911 immediately, because this could leave them in a very difficult predicament. There's no improvement going on. There's no quick relief medication. We need extra help. Additional steps, though, in the meantime, are try to keep that person as calm as possible. Try to get them to take deeper breaths, loosen up any restrictive clothing if possible, and if they do have that medication available, try to help them administer it. I think that'll be a good place to stop today. We'll jump into conscious choking next, and I'll show you how to give abdominal thrusts and back blows.